start from the assessments and the interventions. Really now we are looking at more of the systems and what are those conditions that bring poor health that are really based on our body systems, circulatory system, where we're looking at diseases to do with the hypertension, things to do with the diabetes. Also, we looked at things to do with those gastrointestinal disorders. And we looked at the gastrointestinal disorders of the mouth, where we're looking at the angular stomatitis, we're looking at the chelosis, we're looking at those bleeding gums, the receding gums, the sores of the mouth, and etc. And yesterday we also interested ourselves with other gastrointestinal disorders, where we are looking at the hiatal hernias, where we are looking at those distensions of the stomach into the esophagus or into the chest area above the diaphragm a little bit. And really we saw what could be indicated in these cases, and we saw that overweight has a role it plays in poor health. And we see that these are some of the things that we will discuss with your clients whenever they come, that this overweight is predisposing them to such conditions. So today still we are going to interest ourselves with the renal system. And when we talk of the renal system, mainly we are looking at the system that we require for excretion. And we know that excretion is an important process in the body, whereby waste products are being out. Though sometimes people believe that the digestive system or the circulatory system that squeeze toxic waste out of your body, you will find conditions. And really, when we talk of the renal system, and we are saying that its primary responsibility is to excrete or excess water and nitrogenous waste substances, or we could call them toxic substances from the body. And we are saying approximately 118 liters of filtrate are processed daily, yielding into 1 to 2 liters of urine. When we say that this amount is being processed daily, we are saying that these kidneys play a crucial role in filtering the waste, okay? And then these excess fluids from the blood, they are the ones from which the urine is produced. So on average, when we talk of the 180 liters of blood plasma per day that are passing through these specialized structures, as we will see, which are called the nephrons in the kidney. So this fluid or filter liquid really, which we call the glomerular filtrate, contains the water, the electrolytes, and also products such as the urea and the creatine, I should say. However, we are saying not all this filtered fluid becomes urine. That's when we talk of 180 liters. You could say, oh, really, 180 liters, that is really a lot. We are not saying that all this will turn into urine. Most of it actually will be reabsorbed, because the kidney helps us to reabsorb many substances from the filtrate back into the bloodstream. And on the things that it reabsorbs, we have the water, we have the glucose, and also other fluids, and only actually a fraction of what is filtered is what is turned back into urine. So the urine contains water to dissolve these toxic compounds, and also excretes the urea, and we'll see that basically what is excreted as urea, we are having that, and also the excess vitamins and minerals, the metabolites of drugs, and also the emerging micro contaminants like those nitrogenous wastes. We are saying directly, and we are saying these kidneys are primarily excrete urea, creatinine, or really some people call it.
Yeah, excuse Mazir Robert, I am online. Huh?
Creatine and other people call it.
Did you get me?
Creatinine, and other excess fluid.
Hello?
Yes. Yes, please. You're trying to call. Yes, Majuk.
Hello,
What are you
hello,
trying to
Robert.
say?
Oh, yeah, I am
Hello.
online.
Yes, Majuk. I can hear you clearly.
Yeah,
Yes, please.
yeah,
Am
I
I
am on.
not audible?
Yeah, you are audible. Yes.
Am I audible? Or am I not audible?
I'm getting you. I'm getting you, Robert. I, are you not getting me?
Yeah, it is fine. It is fine. And we are saying this is a nitrogenous substance, and we are also saying high urinary excretion of creatinine signals
Hello.
protein muscle mass loss. Okay, yes, then please mute. I'm getting you, please mute. Okay, so we are saying indicative of muscle creatinine. So any presence of it in muscle out or the malnutrition, I should say. And we are saying understanding creatinine and also the filtration base balance. And we'll see that these imbalances can lead to fatal consequences or what people could call death. And we are saying the body maintains a very narrow pH range that is closely 7.35 to 7.45, and we are saying using buffers in the blood and kidney mechanisms help the body achieve this pH range. And we're also saying that the kidneys regulate acidosis by excreting those acidic products like those from the protein metabolism. Okay. At the end of protein, proteins have been metabolized. So the kidneys will help us remove. So we're also saying that the kidneys also regulate and also excreting the body or the blood are more alkaline in nature. Other functions of the kidney, we are talking of the endocrine function with the hormones. You remember actually above before when I told you about the acids that happen as a byproduct or as a waste from protein metabolism. That's where we are talking of the ureas and the uric acid. So these ones, after the amino acids, after the proteins are broken down into amino acids for energy, these also happen. Okay, then also we are saying that the kidneys also help in this hormonal secretion. So the kidneys help us in secreting renin, and we are saying this renin is required for the blood pressure regulation. I hope you all remember when we were talking about hypertension, and we saw that the kidneys play a role in secreting this renin that is required for the blood pressure regulation, and also the erythropoietin production in the kidneys stimulates the red blood cell production and also activation of the calcitriol, which is the vitamin D by the kidneys, enhances the calcium absorption. I hope we remember this. One, we are looking at the acid-base balance. Two, we are looking at the endocrine function of the kidney. And we are also saying that the kidneys reabsorb water to maintain the balance Okay, you remember we were talking about the blood volumes when we were talking about the hypertension, that with increase in fluid volumes, we tend to look at hypertension. So a lot of factors need to come into play when you're talking to a client who is suffering with hypertension, but also having another condition of renal disease. You need to account for all this. And we are saying that the kidneys reabsorb water to maintain this balance. The renin, the angiostensin, and also the aldosterone system conserves water and the sodium. You remember how when we are talking about both the sodium and the potassium, and also really their role in the fluid balance. Vasopressin also influences the kidney's water reabsorption, and also the antidiuretic hormone, or what you could term as the ADH, increases water absorption in the collecting ducts, and also this is influenced by temperature. For the renin-angiostensin aldosterone system, this conserves the sodium chloride when extracellular volumes are decreased. Right. So, what are those common renal diseases, as we will see? When we talk over the common renal diseases, we are talking about these diseases that affect the renal system. And the renal system, our biggest organ in that system, is the kidneys. Okay. Yeah. And we are saying one will see later on. Yes, please. Yeah. We
Hey, ayana Bradin. No, continue.
yeah, we're talking of the diabetic nephropathy. We are talking of the high blood pressure related damage, blood pressure. That these damages that talked of the polycystic kidney disease, acute renal failure. We understand when we use these two terms, the acute meaning quick onset but very lethal, and also the chronic renal failure, the long-lasting effect of renal failure, and also the end-stage renal disease or the ERD, as we will see later on. When we talk of the diabetic nephropathy, really this is a type of kidney disease that occurs as a complicated high levels of vessels to filter the waste properly, like we have talked about that issue. Really, when we talk of the diabetes, you will see that most of the things that we will see here, that the waste, whenever we talk of the glycosurias, whenever we talk of the hyperglycemias, really we are now at very critical stages in the diabetes cases. So the damage to the nephrons due to the unused sugar in the blood will lead to the glycosuria. And when we talk of the glycosuria, really, we are talking of sugar leakage or glucose leakage in urine. And this hyperglycemia exceeds the renal threshold, causing this glucose leakage, as I should say. And when we compare these symptoms include the polydipsia. Sorry, we are saying that the signs and symptoms include the polydipsia. And when we talk of the polydipsia, here we could say that this is what we call the excessive thirst, when the individual is really feeling very thirsty every now and then. The body is trying to communicate to the individual. Because also of these glucose losses, someone will turn out to become malnourished. And when we talk of the polyphagia, here really we are saying that this happens when a person is thinking, or what we call excessive hunger. The person wants to eat every now and then. So this is usually, particularly in those people with the type 1 diabetes, and the inability of the body to properly use the glucose can lead to this increased hunger, as the cells are not receiving enough energy. Other things, we are looking at the high blood pressure can damage these kidney vessels, impairing the filtration, and also the polycystic kidney disease, which involves the growth of that cyst, which potentially leads to a kidney failure. And really, this polycystic kidney disease is really one to look out for. okay, in clients who come presenting with renal diseases or with conditions with impaired filtration. And really it is mostly people have argued that it is a genetic disorder or it can be inherited. And here we are looking at numerous growth of these cysts that can lead to a kidney enlargement and also reducing the kidney's function. Also, when we talk of the acute renal failure, we are saying this occurs suddenly due to various factors like blood toxic exposure, and also the chronic renal failure when we talk of that acute, we've seen that the only thing is about its sudden onset. Okay, it occurs very sudden due to various factors, etc. And also when we talk of the chronic renal failure, we are looking at a gradual process of loss of the kidney function, also what we call as a chronic renal disease. When we talk over the end stage renal disease, here we are looking at a near total kidney failure requiring hemodialysis, whereby now the body can no longer filtrate and we need a machine to help us filtrate or filter the substrates that are going into the body. Really, when people talk of the dialysis, we need to understand the two forms of the dialysis, where we have this hemodialysis, where we are saying that the blood is actually circulated outside the body through a machine. I am getting here, but that artificial machine that acts as an artificial kidney and which will help us filter the waste products and then also the excess fluids from the blood, and then the cleaned blood will be returned into the body. But also there is the other second form of the dialysis where a special fluid called dialysate or something like that is infused through a catheter, and then it is removed. This waste is actually now we can't filter it anymore, and it is the filtrate is just drained out of the body. So, friends, let's interest ourselves with another topic, and we are looking at still to do with the kidneys. We are looking at the glomerular diseases. Okay, yeah. When we talk of the glomerular, we are looking at this encompasses those various conditions affecting the kidney, or we could call them a group of conditions that affect the glomeruli. Okay, yeah. When we talk of the glomeruli, these are those tiny filters that are in the kidney that are responsible for filtering the waste and also that excess fluid from the body. Okay, so the two types we have the nephrotic syndrome and the nephritic syndrome. Really, those are part of really the two, but though there are a lot of things to do with the membrane, the membranous nephropathy, and also other things that you will see. So, when we talk about the nephrotic syndrome, or what people talk as, yes? Or someone please mute. Whenever I get feedback, I feel someone is trying to ask a question. Okay. Yeah. So please mute. Yeah. So
what do you mean mute? When you talk of mute, what do you mean?
Yeah, I'm telling you to tap that microphone.
Huh?
You tap the microphone so that I don't get sound from your device.
Okay.
Yeah, I get the people who are listening get disturbed. Okay.
Okay, continue.
Fine. Yeah. So when we talk of the nephrotic syndrome, we are looking at this is a disorder or a kidney disorder that is characterized by increased levels of protein in urine. Okay, like we saw that glycosuria, we are looking at increased glucose in urine. But for the nephrotic syndrome, we are looking at proteinuria, where we are looking at increased levels of protein in urine. So low levels of protein in the blood will lead to this edema, all the swellings, and also here we are looking at it being characterized by alterations in the glomerular basement membrane leading to excessive proteinuria, like I've said. And also it is associated with conditions such as diabetes, the glomerular nephritis, and also the amyloidosis and the lupus. Okay, here we are saying that when someone is suffering from the nephrotic syndrome, there is really a high risk of the cardiovascular disease and the hypercoagulability and the abnormal bone metabolism and hypoalbuminemia, which will cause the edema, or you call it edema, any way you feel like you want to pronounce it. All right, so what are the mechanisms of the nephrotic syndrome? When the proteinuria will be exceeding around 3 grams per day, which will lead to hypoalbuminemia, where there is less protein in blood, and also the edema caused due to the altered osmotic gradient and fluid retention. Medical management involves using of the corticosteroids, the immunosuppressants, and also the ACE inhibitors and the coenzyme A reductase inhibitors. When you're talking about this, you will see them in physiology. So how do we manage this nutritionally? Or when we are talking of the nutritional management of the nephrotic syndrome, when we saw one of the symptoms is the proteinuria, when there is a protein present in urine. So here we are looking at really protein intake being restricted to 0 to 1 grams per kilogram of body weight, and also emphasis on high biological value proteins, the sodium, really, and also in extreme cases, proteins are restricted. This will help us reduce on the workload of those kidneys, and also help us in maintaining the proteinuria. Also, we are talking over the sodium, potassium, and the fluid intake adjusted base. We are talking about the sodium, potassium, and the fluid intake adjusted based on the individual's needs. Really, we are saying limiting sodium intake can help control this fluid retention, and also this will help us avoid those foods that are really high in sodium, the seasonings and etc. Also, people talk of the fluid management. Being able to monitor that fluid intake is also a very key when you're managing this nephrotic syndrome nutritionally. For the diet, we are looking at choosing those healthy fats, where we are saying that therapy is less effective when there is for hyperlipidemia, and often this requires meditation. So we are saying choosing healthy fats such as those found in the olive oils, the avocados, the unsaturated fatty acid will help us from the foods like the whole grains and etc. Individualized meal plannings, and also some dietary supplements could play key roles when we are talking about this. Though we are saying maintaining a balanced and nutrient-rich diet will help us nutritionally manage our nephrotic syndrome. So we don't want to really confuse what we call the nephrotic and the nephritic syndrome, as we will see there are these differences here. So when we talk of the nephritic syndrome, we are looking at this being the kidney disorder, where we talk of the acute glomerulonephritis characterized by sudden onset of inflammation. And we are saying here this is really actually just the inflammation of the glomeruli, those tiny filtering units of the kidney. However, for the nephrotic syndrome, we talked about where we are seeing increased levels of protein in the urine. But here we are looking at the characteristic being the increased inflammation in the glomerulus in the nephritic syndrome. And we are saying this often follows after streptococcal infections, those bacterial infections presenting with hematuria. And also hematuria, when you hear the word hematuria, think of nothing other than having that blood in urine, okay, which may appear red, or that cola color, that Coca-Cola red kind of thing. So that is what happens when the inflammation is there, and often follows after the bacterial infection, like I've said. And here in nutrition management, it involves treating those underlying diseases and symptom control. when we are differentiating really between the nephrotic syndrome and the nephritic syndrome, you will see that for the nephritic syndrome presents with the hematuria, while for the nephrotic syndrome exhibits with the proteinuria, like I've said. For the streptococcal infection, we are looking at the nephritic syndrome and the nephritic syndrome, sorry, and not the nephrotic syndrome. So now, friends, let's shift gears and look at that acute renal failure, or what people have termed as the ARF. So when we talk of the acute renal failure, we are looking at the rapid, okay, because when we talk of acute, we are looking at rapid onset, okay, and it is often reversible, a deterioration of the renal function, okay, yeah, and other people have also called it the acute kidney injury in some cases. There are a few things to know here, and we are saying that glomerular filtrate rate, that is the GFR, declines rapidly over hours to days, and also this is commonly occurring during hospitalizations, associations with significant sickness and death, and also especially in the ICU or the intensive care unit patients. The causes and the risks of these, really, we are looking at acute renal failure can develop due to drug overdoses, the intoxication, and also okay. So also the decreased blood flow into the kidneys can result into these conditions such as the severe dehydrations and also the hypotension. Though we had looked at hypertension basically as one of the metabolic syndrome cases, but also let's not forget that hypotension also will have its own challenges that will lead to a person's well-being being affected. Also, we are saying hospitalizations can increase the risk with these patients in the intensive care department. We are looking at it being characterized by the short-term renal function loss and also the glomerular filtration rate declining, like I said earlier, and also it occurring in those hospitalized cases. Then for the pre-renal failure, we are looking at the intravascular volume depletion, okay, and also the decreased cardiac output. Really, we are talking of these decreased blood flows, and also the post-renal, we are looking at obstructions such as the benign prostatic hypertrophy and all those other cancers. Then we have the intrinsic and the parachimal acute renal failures. Really, you could see that we are going deeper and deeper into these physiology terms. But what you really need to know are what these diseases are and what causes them. And if you know what causes a particular disease, you could come up with forms or you could come up with these ways that will help us or that will help a client a certain client over. All right. Then for the systemic we are looking at loss of blood supply due to surgical complications and thrombosis. When we talk of thrombosis, we are looking at that blockage, okay, of the blood vessels. And then we talk of the hypotension. When we talked of the hypotension, we were looking at the blood. Then when we talk about the nephrotoxic injury, here really we are looking at the drug overdose, and also sorry, we are looking at the hypovolemia, where we are looking at the decreased volume of the blood plasma, leading to a reduction in the amounts or in the volumes of blood that are circulating. And then when we look at the nephrotoxicity injury, we're looking at that drug overdose, okay, both the prescription and those illicit drugs, the cocaine, etc., will lead to these acute renal what could be leading to that decreased blood flow to the kidneys, things to do with that severe hypertension, like I had said, leading to shocks and heart failure, or a major surgery needs to be performed. Then for the the nephrotoxic injury, or what you could call the nephrotoxic phase, we are looking at these resulting from drugs such as chemotherapeutic agents for people who are undergoing chemotherapy treatment due to different cancers, and also the toxin. Also, we are saying that here these really the toxins can damage these renal tubules and also cause the necrosis. Examples are those aminoglycosides and also some other issues that could be leading to those heavy metals being drained into the body, the leads, the mercury, and etc. could cause us problems. So phases of this acute tubular necrosis, here we're looking at the initiating phase. That is the reversible period between the onset and the established renal failure, which is typically lasting hours to days. And also here we look also at the maintenance stage, being the second stage, looking at the epithelial cell injury with low urine output, and also those electrolyte imbalances in those 5 to 8 days in the non-uric in the non-uric patients. We talk of oliguria, really we are talking about that patient who is experiencing decreased urine output. Okay, when you say that someone is talking of oliguria, I would say there are a lot of different phases here, but really oliguria means people with a very low urine output. So in the recovery phase, we are looking at the cell regeneration of these tubules and also the gradual return of the glomerular filtrate rate and the normalization of the BUN, or what we refer to term as the blood urea nitrogen. And also the creatinine levels. We saw that when we find creatinine in urine, we start to think of malnutrition, but also after doing this blood product of protein metabolism in the liver. So this is a marker really in the kidney function, and also as the kidney filter urea out of the body, out of the blood to excrete it as urine. So we are saying that this blood urea nitrogen increases due to uremia, and also uremia, that is having a lot of urea in urine. I think so. I think so, yeah. So when we talk of this, we are talking of this is a serious condition where we are having extra urea or extra waste products in the kidneys, which include mostly that urea and also the creatinine. So also this creatinine accumulates in the blood when the kidneys fail to excrete it properly. And we are saying its treatment focuses on addressing these underlying causes and also managing those key complications, and also the fluid electrolyte balance, the diuresis, and also the monitoring of that blood urea nitrogen, and also the creatinine levels are also essential when you are managing this acute renal failure. The medical interventions include supportive care, the diuretics, and also the replacement therapy if necessary. When we talk of the renal replacement therapies, it's recommended for patients with azotemia, which is elevated blood urea nitrogen. and also the creatinine levels, and also requires interventions to correct imbalances and also provide brain support to other organisms. So this replacement therapy, we had talked about them, really most of them we are going to be just rushing due to a time constraint. For the hemodialysis, we are saying this is a gold standard for renal replacement therapy that is suitable for the hemodialysis stable patients, and we are saying it is also we have the next, which is a continuous hemofiltration, what we call the CVP, or the continuous arteriovenous hemofiltration, the CABH, which may be used for those unstable patients relying on the artificial pump for really blood flow. Both these methods involve removal of these nitrogenous waste products and excess waste from the body. The differences between the acute kidney disease, which has a sudden onset due to those clinical insults, or the acute medical conditions. But when we talk about the chronic kidney disease, we are looking at it developing over time and really leading to irreversible kidney damage if left untreated. The acute kidney disease may progress into the chronic kidney disease if left untreated and not addressed promptly. So what is the medical therapy or medical nutrition therapy for the acute renal failure? We are looking at protein intake. Okay, and also we are saying we need to restrict severe azotemia, and to reduce the uremic symptoms of this. All right, and also we are saying that those mechanisms trying to downplay the role of basketing. We talk of the hyperphosphatemia when we have a lot of phosphates in blood. This is common damage managed with the phosphorus binders to prevent bone and mineral imbalances, really, I should say. Okay, I hope we are clear this far. For the nitrogen balance in the acute renal failure, some calculations here and there that you will go and do some work on. And also this urea nitrogen appearance is used to determine the nitrogen balance in these acute renal failure patients. And this UNA, or the urea nitrogen appearance, accounts for the nitrogen intake, the losses, the excretion, and also providing insight into the protein metabolism and the renal failure. Really, some of these calculations you may not do on your own, because from the medical school you will be able to help you. But in case they are not around or they are not available, you should be able to do these calculations for yourself. So we are saying monitoring this urea nitrogen appearance will help you to assess the effectiveness of the dialysis, and also the nutrition interventions takes into consideration the intake, the losses, and also the exclusion. So the nitrogen appearance, we are saying this is a gold standard. Okay, yeah, for determining this based on this nitrogen balance for patients with acute kidney disease, better used for those clients that are undergoing this replacement therapy, the hemodialysis or the peritoneal dialysis. We say the difference in this could be due to how the process is being done. For hemodialysis, really, the filtered blood is allowed in, but then we allowed back in, and really it cannot work on those wastes. So we have an example here when we are talking of the post-dialysis, where we're looking at the BUN1, when we're looking at the blood urea nitrogen, and the BUN2 etc. So you will fill into those different. What I can tell you really is that we have constants in this formula. For people who have been doing calculations for a while, you understand when you talk of a constant is what is required to be there. That really doesn't end. Okay. When we look at the BW1, that is the body weight initially, then W2 fun being 24, that is what is there post dialysis, that is after dialysis. When we look at the BUN2, that is pre-dialysis, before the dialysis is happening. So you will see how these are all fitting into this particular formula to give us the urea. Nitrogen appear. Okay. Yeah, hopefully you will be able to all the urea nitrogen appearance. You will be able to get the amount of protein needed when you look at really this 6 finger also positive. We'll be able to understand that particular and developing over time disease. Then we are also talking about the glomerular filtration rate being impaired, decreases as the kidney disease progresses. And also we are looking at the urine output and the weight balance. At the end stage, renal disease management may involve as immunosuppressive candidates, urea nitrogen, or the BUM, and the creatine, or what we consider the CRNA, and this is synonymous with uremia. And the symptoms of the uremia may include the itching, and also this will also indicate phosphatemia, where we were saying this is the increase of phosphate in the diet. Really, as a chronic kidney disease progresses, the requirement for protein decreases, and here we alleviate the strain on the kidneys and the need for dialysis. So, what is the real rationale? Why do we restrict the proteins to this kidney disease? This will help, and also it will help kidney disease, which will ultimately delay the need for dialysis. We will talk about dialysis that are now a little beyond management in a normal way. Additionally, we are looking at reducing the animal baselines and also the metabolic acidosis. Remember that the acidosis comes from metabolism of protein. So for hemodialysis and the peritoneal dialysis, we are saying for the peritoneal dialysis may result in more protein losses than the hemodialysis, requiring a little bit of high protein to compensate for those losses. And we are saying during dialysis, protein losses so can increase protein intake, and also for the glucose absorption during this peritoneal dialysis, dialyzing fluid to prevent a weight gain. The sodium intake should also be fluid out. Vitamins are being lost due to the body's inability to filter them back into the body. For the blood urea nitrogen and indicates high blood urea. nitrogen indicates the high recovery, and then as an indicator of that kidney function. We say when there is a lot of creatinine in the blood, we start suspecting that there is a high protein metabolism taking place. And when there is a high protein metabolism or high protein breakdown, we start to suspect malnutrition being there. And also, we are looking at the potassium, phosphorus, and calcium, and also the hyperphosphatemia can lead to secondary hyperthyroidism and also those bone disorders. And also the calcium level should be assessed during assessed using ionized calcium to account for albumin binding. These are the biomarkers. The sodium, we are saying high sodium indicate dehydration, and also this will require increased fluid intake rather than restricting the sodium. So the hematological indicators for the glomerular filtrate rate, we are looking at anemia of chronic disease that may require a synthetic erythropoietin rather than iron supplementation, and also the glomerular filtration rate serves as the we have some slide missing. We are saying that the glomerular filtration rate serves as the best index for the kidney function, and guys, our nutrition recommendations are really to assess the fluid management and also the nutritional protein catabolic or the breakdown of these protein. Gets the protein intake and utilization, which will help us in assessing the dialysis of the patient. Okay, the total energy weight gain. Okay, the metabolism is building, is breaking down. Okay. Yeah. So, increased energy value of the meal plan without affecting the electrolyte levels. If a patient with a hyperlipidemic, if a patient is hyperlipidemic, so then some foods may be restricted. When we talk of hyperlipidemic, we are looking at more lipids in blood. So most of this thing you should be able to know when you hear hyperglycemia, when you hear hyperglycemia, when you hear hypoglycemia, hypertension, hypotension. These are things that you should be looking for. And also, simple sugars can increase the levels of LDL. Usually, we are looking at the acid ash diet being indicated. Usually, the animal products, the meats, the cheese, the grains being emphasized, the fruits and vegetables being indicated, and also the increased acidity of urine. And vegetables are emphasized, the meats and grains are limited, and also the increased alkalinity of urine, which is containing the sodium, the potassium, calcium, and the magnesium. Really, also for the nutrition therapy of the chronic disease, as we are monitoring the fluid status, the electrolyte imbalances, and then second, we are preventing the protein energy wasting, and also we are looking at the common comorbidities, which is the hypertension, cardiovascular diseases, and the diabetes mellitus. And also, let's try as much as possible to assess for protein energy malnutrition. So the 7-point subjective global assessment scale will also be used when we are looking at this, and also review the stages, the initial stages, the management stages, and etc. Of the acute renal failure, and also the anuria. We are looking at below 50 mils, the oliguria, very low urine, less than 500 mils of urine, and also these probiotics are encouraged because of the gut bacteria increase the oxalate absorption because it is used by the probiotics. For this, really, the MNT, you realize I'm going down with a little bit of food. I understand at some points my voice has been shaky, but please try to bear with me because this is our last slide. Okay, so for this medical nutrition therapy, for these, we could call it urinary tract infections, or you could call them arteritis. We are saying these are usually caused by the infection. Okay? And the simplest and the most common abnormality is. So for the medical nutrition therapy, we are looking at increased fluid intake and things to do with the sorry, and things to do with the cranberry juice being indicated in this. This has an antibiotic effect growing in this disease and can also acidify the urine, making the surrounding environment of the infectious agent more hostile to them and limit their growth. So, and also the neutropenic diet is encouraged since the patient is using those immunosuppressant drugs to avoid contracting those foodborne illnesses. Maybe friends allow me to stop here for today's engagement. But we have really looked at what causes the kidney diseases, the different stages of the kidney diseases, the acute kidney disease. Then we have also seen the chronic kidney disease and how we could use our nutrition and medical management, and what are those contraindications and the indications. We are looking at the proteinuria, we are looking at the presence of protein, trying to show us that there could be malnutrition. We're looking at the sodium, the phosphorus being present. We're looking at some of the symptoms like dysphagia and etc. So friends, allow me to stop here unless there is something. For the calculations, please let's go over them because these are simple calculations and that have been constant everywhere. Okay, yeah. So this urea nitrogen appearance really these are simple calculations that we will have to go on to go over. Okay, friends, I thank you here for today's engagement. Let's meet. Do you have? Right. If there is nothing, have a good evening.